So we're recording this right now. I turned the recording button on because we're going to be recording this session, and you'll hear a little bit more about how to get the recording during the presentation. While we're waiting, I might as well just make a little announcement that people have a question about the recording from the first webinar is up on the at the NTG website now, but we'll talk a little bit more about that. You will be reminded about that throughout this presentation. Got one more minute. So I think it's about 1 o'clock, right, Marianne? Gives it a little high sign. So hi, welcome. So I think we're ready to get going. So thank you for for joining us for today's webinar. And the topic is early screening for cognitive changes. And my name is Kathy Service. Hi, and I'm a nurse practitioner and on the NTG Board of Directors. And I'm also the facilitator for the NTG's online family support group for those families who have a member with intellectual disabilities who is also living with dementia. So for those of you who are unfamiliar with the NTG, NTG stands for National Task Group on Intellectual Disability and Dementia Practices. We are a 501c3 not-for-profit organization, and our mission is to advocate for services and supports for people with intellectual disabilities who are affected by Alzheimer's disease and other dementias, and also for their family and paid staff and agencies. And we do this through a series of efforts, including federal advocacy activity, producing materials related to dementia, including practice guidelines, screening tools, education and training curricula, and workshop, agency and family-based information, and other technical materials, including provision of technical assistance. So also, before I introduce the moderator and my esteemed colleague, I'd like to cover a few what they say housekeeping points. First of all, everybody is muted, right? Please enter technology questions in the chat box. Questions related to the topic area should be entered into the Q&A, not the chat box. Today's webinar is being recorded. Okay, you see the recording button on there, and we'll be able to share a link with you 72 hours after the event is completed. And the recording will also be posted on the NTG website, as is the first session's recording. Language translation is available for closed captioning, and as a participant, you can self-enable and switch languages by clicking on the Show Captions arrow at the bottom of your screen. And we also welcome your comments and questions, and you can please look at the Q&A box at the bottom of your screen And if you think of a question at any point during the presentation, just click on that button and type your question in there. And I'm going to be holding them until after our presenter speaks at the end of the event. And also, if we don't get to your question, they will be answered and they'll be sent to you when you get the recording. So please don't put your questions in the chat box. That chat box is really just related for technology or technical questions that don't relate to the content of the webinar. And we aren't going to be using the raised hand feature during today's webinar, so please refrain from using that. Really important for us here who are the planners is that at the conclusion of the webinar, there's going to be a brief survey. Here it is, the access code that we'd like you to complete that will provide us with feedback about today's webinar. And the survey link and QR code, and you see that right there, are displayed on the screen. And this means a great deal to those of us for planning. So please take the time to complete the survey. Thank you. Okay, now onward. I am really delighted to introduce a colleague from the NTG's Board of Directors who has become a treasured friend and is today's moderator. So please welcome Marianne Barbera, who's the chair of the NTG's Family Support Committee, and she will tell you about yourself and introduce our speaker. Welcome, Marianne.
Thank you, Kathy, for your kind words. I have had the honor and privilege of working collaboratively and closely with Kathy as we have focused on attending to families' needs. We have become great friends in the process. For those of you who attended our previous webinar on the process of aging, we welcome you back. For those of you that hadn't registered for that webinar, we welcome you today to our second webinar. It is an honor and privilege to be part of today's webinar as moderator. Before I introduce today's speaker, let me tell you a little about myself and my involvement with NTG. In 2016, my beautiful beloved sister, who was an individual born with Down syndrome, started showing signs of cognitive decline. As I began my search for reputable resources and support to help guide me in learning more so I could provide the best care possible for her, I found myself unable to find the resources and support I so desperately wanted and needed. Over the course of the next several years, I did locate some helpful resources, but it wasn't until 2021 that I learned about NTG and the extremely valuable, reputable resources and monthly support group that they offer. I was so overwhelmed with gratitude for finding what I needed that I made a promise to myself in honor of my beloved sister that I would do my part to help minimize the likelihood that other families may experience the same difficulty in finding the information and support they need. As a result, I became part of NTG's Family Support Committee, was elected to become a member of the board, and eventually became chair of the Family Support Committee. I am also involved with our monthly virtual support group, assisting our facilitator, Kathy Service, and sharing my lived experience with the group members. With this involvement, myself and many other board members and committee members created an IRB-approved survey to ascertain what families felt they needed regarding aging and caring for their loved one with an intellectual disability. The results of the survey indicated a few key areas which helped us to create our very first family webinar series, which has been an ongoing collaborative effort from NTG's board members, committee members, and our Director of Operations. Today's session is the second part of that webinar series. Additionally, I'd like to mention that this webinar series is able to be offered to you free of charge due to the generous donation from a family that wishes to remain anonymous. So at this time, without further ado, I would like to introduce to you today's speaker, Dr. Michael May, who will speak about early screening for cognitive changes. Dr. Michael Benjamin May currently works as a clinical director for the Merrick East ICF program in Philadelphia, Pennsylvania. Via this role, he supports individuals with a dual diagnosis in mental health disorders and intellectual disabilities by providing therapeutic, individualized emotional supports, delivering clinical supervision to behavior specialists, conducting training with direct support professionals, DSPs, on the implementation of evidence-based interventions, and analyzing data relevant to individuals' progress towards the achievement of goals that are designated to reduce barriers relevant to the advancements in quality of life. In addition to his responsibilities as clinical director, he has also presented at numerous professional conferences on a variety of topics, including providing emotional supports to individuals with intellectual disabilities and promoting fidelity in behavior program implementation. Prior to his current position, Dr. May has also worked as a DSP, special educator, mental health therapist, and behavior analyst. Academically, Dr. May earned a Doctor of Education in Special Education from Arcadia University in Glenside, Pennsylvania, where his dissertation explored factors affecting implementation of treatment plans by DSPs for individuals with intellectual disabilities. He also has a Master's of Art in Clinical Counseling Psychology from LaSalle University in Philadelphia, Pennsylvania, and a Bachelor's of Science in Special Education from Penn State University in State College, Pennsylvania. In addition to being a certified special education and middle school math teacher, Dr. May is also a board-certified behavior analyst, BCBA, licensed professional counselor, LPC, licensed behavior specialist, LBS, and has a competency-based clinical certification from the National Association of Dual Diagnosis. At this time, I'm going to turn the floor over to our presenter, Dr. May.
Thank you so much. This is such a great honor to be presenting here. And I also really want to just thank all the great work that's done with the NTG. It's such an amazing organization. And I also want to thank everyone here for, I was going to say giving up your afternoon for a little bit, but I know some people have morning, some it's evening, but just giving up some time to really discuss this topic. I know it's not a easy topic to talk about, but it is very critical. And I really want to thank everyone just for your dedication to your loved ones. Can you go on to the next slide, please? Yes. What I would like to talk about is really what can we do prior to our doctor's appointments, the annual appointments with the PCP, the medical doctor, so that the medical doctor can get a full picture of what's been going on with your loved one between the time period of the previous appointment to the current appointment. And there's a great tool that we're going to be talking about that would help us do this. It has multiple functions, but the function we're going to talk about for the purpose of this training is the NTG Early Detection Screening for Dementia. And you'll be getting a copy of it. It'll be at the end of this PowerPoint, and you can download it or you can complete it on the computer itself, and it is available in a bunch of different languages, some languages I never even heard of. And we're going to just see it being used at the very end of this presentation. And then I'm looking forward to, at the end, having some time to ask questions, have comments, because this is a very critical issue. And I really admire everyone's dedication to your loved ones. And I really want this to be as informative and as beneficial as possible. Can we go into the next slide, please? Full disclosure, I am going to be talking about the NTG Early Detection Screening about dementia. It's a great tool. As a clinical director, we use it all the time. I work with adults who carry a dual diagnosis of intellectual disability and some other mental health disorders. And it's been an amazing addition to our supports we provide to our individuals. A disclosure, I don't, oh, do you mind going back? I apologize, thank you. I don't make any money from when you use this. Obviously, the form is free, and I'm encouraging people to use it just because I think it's a great tool. Not like I'm making any financial benefits or anything like that. Just want to do my disclosure statement. Can you go to the next slide, please? So for the focus of this presentation, we're going to be talking about the importance of the medical professional to really have a precise image of what's been going on with your loved one between the previous appointment and the current appointments. Why is that so important? Well, there's a few reasons. To name a few, maybe it's to help identify proper medical treatments. It could help with long-term planning care. Maybe from there, they can provide a few referrals, maybe to a neurologist, a psychiatrist, an occupational therapist, a mental health therapist, whatever. And they also can also recommend or lead you towards some other non-medical interventions, such as support groups, social skills groups, etc. Can you go to the next slide, please? Thank you. Some important information that you really would like the medical doctor to know about. They should know about what recent losses have your loved one encountered over the past year. And when I say losses, I'm not just talking about deaths of loved ones. It could also be changes in jobs, loss of the people they live with. A staff they used to work with a lot is no longer working with them. A lot of our individuals who from my experience, they strive on that consistency, and those changes in consistency that may seem minor to someone who does not have an intellectual disability can be dramatic to them. Other things we would like the medical professional to know: were there any mood changes over the past year? Have they noticed any changes in behavior, such as difficulty completing tasks? Tasks completed at slower rates? Have there been changes in their appetite? In their sleep? Are they sleeping more? Are they sleeping less? Are they getting the days and nights mixed up? Personality changes or any other potential memories concerns. And, this information can also help the PCP make determination of what is typical aging or what could be a cognitive deficit. Can you go on to the next slide, please? So it's recommended that prior to doctor's appointments, you really want to talk to everyone who works closely with the individuals about potential changes that have been occurring over the past year. And when I say everyone, I mean the people who worked with them closely over the past 6 months. So, other family members, maybe their job coach if they are working. Maybe if they're in a residential program, they're direct support professionals. And you really want to record all of these concerns and be able to have an open and honest conversation with the PCP at the appointments. Now, I know a lot of times, at least with me, I don't like when people talk about me in front of me. And, sometimes you may want to offer your loved one an opportunity. You don't want to, if you don't want to sit in, you don't really want to be part of this conversation, you don't have to. You want, maybe they can wait in the waiting room while you have that conversation with the PCP. I mean, we really want to empower your loved ones and, do what makes them feel comfortable. Can you go to the next slide, please? I know we speak about, making sure we have all this information so you're ready to explain everything to the PCP prior to the appointments. You got everything together. You really want to discuss things. And we live in the real world, and we know there are times when we forget to mention some, critical piece of information. I mean, look, I can tell personally, I go to the doctors a lot, and I'll say, wait a minute, you know what? I should have mentioned that to my doctor. I totally forgot. Or you may focus on one symptom and overlook other things. And unfortunately, from my experience, a lot of PCP visits don't include a cognitive examination. They mainly focus on the physical health and really don't focus too much on the cognitive health. And also, we know how doctor visits are. There's so many individuals they have to see and such little time. So doctors, are often rushed. And even if they're not saying it, sometimes those feelings that, it just seems like he just wants to, or she just wants to end the session and go on to the next patient, can make us feel anxious, and we can potentially forget things. Can you go to the next slide, please? So I recommend before the annual PCP meetings is to complete the NTG early detection screening for dementia. And it really, we're going to go over it, but it really just provides great information about changes that occurred with the loved one, with your loved one over the past year. It asks questions that relate to things dealing with daily living, their language and communication, sleep and awake patterns, their ambulation, memory, behavior, affect, other changes that they themselves notice, and some other notable things that are just relevant to mention. And, if there's no changes from last year to this year, then you know what? It'll be a very quick form. If there are some changes, you'll have them to be able to just present it to the PCP. Can you go to the next slide, please? And when completing this, we do want to ask people who are familiar with the individual and really work closely with them for about 6 months at least. And the reason why you want to ask multiple people, because we all display behaviors differently. And, we may not notice any changes in the house, but maybe in their employment, their job, their job coach or program staff or whatever notices the change, or vice versa. So it's really good to speak to everyone's perspective, not just one perspective. And it's really good if we can have it like a discussion. At my facility, we do it during our annual interdisciplinary treatment meetings. That's where we develop the ISP, the individual service plan. And we use this form really just to guide a discussion. And because at that meeting, we have representations of the people who work closely with the individuals. And if those people are unable to attend for whatever reason, they would have the form ahead of time to fill it out, and their responses will also be presented at the meeting. Can you go to the next slide, please? So, although we're just going to be using this form to talk about helping us prepare for when we take our loved ones to the annual PCP appointments, this has many benefits using this form. It's great for a baseline. As a clinician, it's great for me to, when we completed today for an individual, I can look back at last year's, 2 years ago, 3 years ago, and compare and see if there's any changes. It's also a great thing to spark communication, to really, develop a conversation. I was like, what are some supports that this individual would need in the future? It'll help identify areas of future goals. And also, it can help other professionals rule out other potential concerns, whether it be medical or psychiatric. Can you go to the next slide, please? So ideally, we want to start using this form for individuals who have Down syndrome around the age of 35, and it should be done every year since. For an individual who doesn't carry a diagnosis of Down syndrome, we really want to start using it around age 50. However, you can start using it before 35 or 50 if you're noticing some changes sooner. Also, it doesn't have to be done every year. Let's say we want it done at least once a year, but let's say within, the 5-month mark, you notice a lot of changes. You may want to do it again in that time period. Because, we all change at different rates. And you can even compare it to, 5 months ago, they were like this, now they're like this. Can you go to the next slide, please? The first section of the NTG really just focuses on just the demographic information. And it's also good for the PCP to also have that information because, a lot of times they do see a lot of patients, so they may not need a little reminder. So for example, it asks about the current living arrangements. The PCP may forget, do they live in a group home? Do they live here? Do they live wherever? Can you go to the next slide, please? The next section asks questions about their mental and current health and how it compares to last year. Is their physical health and mental health better or worse or about the same from last year to this year? It asks about any other conditions that they may have, whether it be issues with vision, hearing, etc. And also asks about what are significant losses that the person had over the past year. And again, as I mentioned before, we're not just talking about deaths, but anything that dramatically seems to affect them, a change that really affects them. It could be, staff who they used to work with forever retired. And it also asks about seizures if they have a seizure disorder. Can you go to the next slide, please? Then it goes into the sections that asks about activities of daily living, language, sleep, ambulation, memory, behavior, affect, their perspectives, and other notable changes. And we're going to go over each one. Can you go to the next slide, please? So when I say activities of daily living, those are things, do we notice any changes with the ability to bath? How about wash themselves? What about dressing? Have you noticed them dressing at inappropriate places or undressing inappropriate places? Excuse me. Are they needing extra help with eating? Do they need help using the bathroom? Are there more issues with incontinence? And with each of these questions, you're going to mark it as always been the case, but worse, is a new symptom or does not apply. So for example, if we have an individual who is NPO, so he doesn't or she doesn't eat anything by mouth, under, needing extra help with eating, we'll put down, doesn't apply. If someone always, undressed at inappropriate places, we just put down always been the case. One example I do want to use with this one is we had this one individual who I'm currently working with who, oh my God, dressed immaculately. If his clothes all matched. He used to criticize me for the way I dress, and he didn't let my excuse of me being colorblind let me slide. Even if I'm colorblind, I should still match according to him. Unfortunately, he now carries a diagnosis of dementia, and lately there's been times when he's been walking down the steps with his shirt on inside out, forgetting to put on pants, shoes on the wrong feet, different socks. Can you go to the next slide? With language and communication, any changes with their communication? Do you see them getting lost in sentences? Now, again, if they don't communicate verbally, how about with any changes in their ability to communicate, whether it be through sign or some augmentative communication device? How about with writing and reading? And if they were never able to write or read, we'll just, put down does not apply. Can you go to the next slide, please? For sleep, it asks questions about how are they at night? Are they getting the days and nights mixed up? Are they sleeping more during the day and up at night? Are they sleeping later? Are they getting up earlier? Are they getting up later? Are they going to bed earlier? Are they going to bed later? And these are, may seem like simple questions, but these are just relevant stuff for the PCP to know. Can you go to the next slide, please? Next asks about ambulation. And obviously, when we get older, our walking does change. So it does ask questions about recent falls, issues with gait. Do they need additional supports with walking? And again, that could be part of this typical aging, or it could be something else going on. And again, that's why it's good for the PCP to know. Other questions is, what about when the floor changes? Do you notice any fearfulness? If there's cracks in the wall or the pattern changes, do they get fearful? They refuse to walk there. In one of our houses, there was this mat that they put out. It was for Halloween. It was like this black mat that had Happy Halloween on it. And one of the individuals was scared to step on the mat, and they had to remove it or he wouldn't go into the house because, he he had some cognitive, he had some neurocognitive impairments, and to him, he saw it as, oh my gosh, this is a hole in the ground. Can you go to the next slide, please? And then, of course, questions about memory and things such as, are they putting things in incorrect spaces? Are they forgetting people's names? Are they having difficulties learning new skills? Are they losing track of time? Are they losing things a lot? One particular individual who they really knew something was really wrong was he was an individual who had to have everything in a certain space. If you move a book off a bookshelf, you better put that book back or you'll never hear the end of it. And they started noticing, he was putting things in incorrect spots. He was putting some stuff under his bed. And that was like really the first sign they saw that something seemed to be changed. So even though he really didn't notice any changes at when the NTG-EDSD was done at the annual thing. I think this was at the 6-month or 7th-month mark, and we did it again at the 7-month mark. And it is also difficult. I think this is why it's so important to really discuss and understand, about dementia, because especially for people who worked with the individual, loved ones, and when loved ones have difficulty remembering you, have difficulties remembering your name, it can be very hard. And that's why, little side thing, make sure we also do some self-care for yourself as well. Can you go to the next slide? How about any other behavioral changes? Are they more, withdrawn? Have you noticed them wandering around? Have you noticed them talking to themselves as being a new behavior? Have you saw their loss of interest? They used to love doing a particular activity. Now they don't want to do anything with it. Have you noticed them being more obsessive about things or repetitive behaviors, like, walking up and down in a certain pattern? Have you noticed them hiding things? That one individual I was talking about before, who used to love everything in one spot, who everything had to be in a perfect spot, in a perfect area. You can't move things unless you put them back. One of the things we saw about him was hiding some stuff. He was hoarding things under his bed. Had they been more impulsive, less confident in their skills? Have they seemed more depressed? Have you seen like an increase in some like anger, whether it be aggression or verbal aggression? Have they been someone who used to be like the life of the party and now they're more withdrawn? Can you go to the next slide, please? The next one asks about the individual's perspective on their changes. And I know this is a very abstract thing for a lot of people I work with, at least, because it asks about, have they noticed any difference in their abilities with regards to, are they hearing things? Are they having any changes in what they can and can't do? Are they thinking, are they having more worries or something? Do they notice any changes in their interests or their memory? And for a lot of individuals, this can be a very abstract concept. If I want to teach a pen, how someone to identify a pen, I can go over the critical attributes of a pen. I can show you examples and non-examples of pens, and you can eventually distinguish a pen from a pencil. That's easy. But things such as ability, thinking, interest, memory, those are very abstract concepts. And also, if they have difficulties, they may not understand what was a year ago. You may even say, refer to a holiday. Hey, do you remember 4th of July? Have you noticed any changes in you from compared to how you were during 4th of July? Can you go to the next slide, please? And the last one just talks about any other notable changes such as gait, personality, friendliness, assertiveness. Have there been changes in weight? Have there been any abnormal involuntary movements? And in this section, we are also usually put down just any other changes. Like, for example, we have one individual who I'm currently working with, and one of his symptoms of his neurocognitive disorder is that he recently started attempting to eat non-edibles. He's having difficulties distinguishing edibles from non-edibles. So, like he was attempting to eat paper. Can you go to the next slide, please? And then the final section just asks about potential medical concerns, and it asks, is this always been the case, or is this a newer problem within the past year, within the past 5 years, or is it not an issue? Can you go to the next slide, please? I know I mentioned before that as a clinician, I use the NTG EDSD as a good way just to get a baseline on the individuals I work with. However, if you really want to do a good baseline for your loved ones, developing a life story, and there's some actually links to YouTube clips at the end of this PowerPoint that will show you how you can do them. But things such as, videos or a memory book of pictures of their friends growing up, their pets, their family members, videos of them doing things they used to love to do. Let's say they used to have a job bagging groceries. Maybe you take a video of them bagging groceries. Preferred music, places, pictures or videos of places they used to visit, and other maybe pictures of their childhood homes, videos of them, as a child. Can you go to the next slide, please? I just want to go spend the next few minutes just going over a case study. And this is based upon 3 different individuals that I kind of meshed together, and I added some other stuff in there just from my memory, from my imagination, just because I don't want to share someone's personal information. But for this case, we're just going to call this person Frank. He's a 38-year-old man. He carries a diagnosis of Down syndrome and insomnia, so he has difficulty sleeping. He lives in a group home with 3 other individuals, all of whom are at similar levels as him. He receives 24-hour staffing. He attends a day program 5 days a week, and his mom visits once a week, or he would visit her. Can you go to the next slide, please? During the annual ISP meeting, interdisciplinary treatment team meeting where they develop the ISP, the individual support plan, we use the NTG-EDSD as kind of discussion tool to see if there's been any changes with the individual. And at that particular meeting was his mom, the 7 to 3 DSP, who works with him from 7 a.m. to 3 p.m. And the house manager was there, but the house manager has a report from the DSP who works from 3 p.m. to 11 p.m. and the DSP who works from 11 p.m. to 7 a.m. His day program instructor was there, and his behavior specialist was there. Can you go to the next slide, please? What they identified is needing more supports with bathing. For example, last year when provided a washcloth and a verbal prompt to wash a particular area of the body, he was able to do it independently. Now he's completely dependent on staff. Can you go to the next slide, please? Some newer behaviors. He was someone who spoke fluently, great expressive and receptive communication. Now a lot of times he's communicating and is described as rambling and not making any identifiable words. Can you go to the next slide, please? He does carry an insomnia disorder, so he has difficulty sleeping. However, during a time period between June and December, he was sleeping about about 4.5 hours a night. This is a decrease to previous years. Can you go to the next slide? With his ambulation, there was no change. They noticed that he's having difficulties recognizing naming his housemates, his familiar DSPs. He's difficulty locating things in his house. They actually had to put a icon of a toilet on the bathroom wall just as a prompt so he knows where the bathroom is. He's been placing things in incorrect spots. He's been requiring additional prompts to complete simple tasks. Can you go to the next slide, please? They also report that he's been a little more argumentative and non-compliant. When I say non-compliant, he was asked, to do something and something, would you want to do this? It's just no. And it's something, what I actually base this on is a real person. You would say to him, hey, Frankie, his name's not Frankie, would you want to put on your coat? He would say, no, I don't want to, but then he'll put on his coat. With respect to the social involvement, someone who used to be the life of the party is now more of an introvert. Other symptoms they've been noticing is he just seems more depressed, crying more often, less confident in his skills. He seems more nervous. Can you go to the next slide, please? He didn't report any changes, but that could also be due to it being a very abstract concept for him. And they also notice that he appears less extroverted and he's more distracted. Can you go to the next slide, please? So recommendations that were made by the treatment team is to present a screening at his next annual PCP appointments, to consult a neurologist, to make a referral for neurologist, and they will bring this form to the neurologist so they can look at it. To have a referral for AOT consult to support, see if he needs any additional supports with bathing. Developing a daily data sheet to identify symptoms that could be related to a neurocognitive disorder and have his DSP complete them, just so we get a better sense of what's going on, the times these behaviors are happening, is anything else going on in the environment related to those behaviors. He was having an hour sleep log, which was brought down to a 15-minute sleep log. So every 15 minutes they do a check as opposed to every hour. And a staff training on aging and dementia, just so they get a better sense of what's going on with him. Can you go to the next slide, please? This is the NTG-EDSD. It's free on the website, and you can do it on the computer itself, or you can print it up. And it's just a very simple form to use, and it's very user-friendly. And as a clinician, I can't speak more about it. Can you go to the next slide? And is offered in many languages. And like I said, some of these languages I'm not familiar with myself. And can you go to the next slide, please? This is just some good resources about, in addition to the NTG, which has amazing resources. These are just some more about supporting loved ones and also developing memory books for the loved ones. Can you go to the next slide? And this is some YouTube clips on making these memory books for people, for loved ones who are aging. And the next slide is the references. And I really want to just thank everyone for giving me the opportunity to speak here. I think the NTD is such an amazing organization, and I'm just so honored to be able to speak to everyone. And I'm also equally as honored that each of you gave up some time to hear about this and all the support you provide to your loved ones. I guess we're going to hand on to some comments and questions.
Thank you, Dr. May. That was a wonderful, extremely informative presentation on early screening for cognitive changes. And thank you for allowing us to spend some time with you and for your sharing your knowledge with us.
My pleasure.
You're very welcome. At this point, we will begin to take participants' questions. Throughout Dr. May's presentation, Kathy Service and Adel Hergy have been monitoring both the chat and Q&A. Remember, if you have a question that you have not submitted, please enter it into the Q&A and we will get through as many questions as time allows. We will now begin to read and respond to questions that haven't already been answered.
Yeah, right. We've got a number of questions, and I just wanted to make two quick comments. First of all, as a nurse practitioner, that the EDSD is a great tool, because dementia is a condition or disease by exclusion. So it helps us as healthcare providers to hone in on other possible conditions that are potentially correctable. So that tool is extremely valuable in many ways than you realize. The other thing with the EDSD is that we have a guide on the website that you can share with your primary care providers or anybody who's using the tool. It specifically kind of describes the tool for them. So you may not have to kind of go, it gives them a basis about the value of the tool. So here's some of the questions. I'm going to go from the beginning. We've got some great questions here. And somebody asked, is there's an easier method for screening individuals with intellectual disabilities? She once took somebody for screening and it was a long session and frustrating to the person. So do you, I mean, this EDSD seems to be the answer to that, but I'll let you answer that, Michael. And I have another question that probably goes in part with this.
Yeah, that must have been very tough for you and your loved one to have to be part of that long conversation. And I know it's difficult to really have such, these kind of conversations. And I think, Kathy, I have to agree with Kathy. I think the NTG EDSD is the answer to that. If you have something like that ahead of time, then the PCP wouldn't have to spend so much time, or whoever the doctor is, asking all those questions.
Yeah. You know, the thing I think about, Dr. May, is that they maybe have talked about maybe other kinds of neuropsychological testing that is done very often with others. You may want to chat about that a little bit for people.
Yes, there are other tests that will be done by the neurologist, and I'm not a neurologist, so usually from my perspective is we would complete this, and if we do feel that a neurology consult is recommended, the neurologist would do some assessments, and to actually diagnose someone with dementia, it's, you'll need a medical and a cognitive assessment. So, unfortunately, I'm not a neurologist, so I wouldn't be able to answer what particular assessments I would recommend.
Okay, great. Sorry, I'm looking at now, get into some of these things. Now, somebody is asking about the use of, and maybe this is in your area, about the ketogenic diet in terms of treatments, but maybe we may be talking a little bit in other sessions a little bit more about post-diagnosis, et cetera. But do you have any experience with that, Dr. May?
No, I don't.
Okay, great. Now, this is a good question. So how do you get the doctor or healthcare provider to administer this test? And the person that she's talking about is a neurologist in a dementia clinic. You have any words of wisdom?
Yeah, first of all, thank you so much for your work you do. I actually recommend when you have a treatment meeting with the individual and their loved ones and people who know them, to really bring this form with you and use it as kind of a guide, and just really to spark communications. I hope that answers your question.
Yeah. Somebody had a question about communication, could it be dementia if a person used to say reliable facts about memories and starts to make claims about memories that never happened? For instance, if the person was had a broken leg, but they're claiming that they were airlifted to a hospital. What do you think about a complaint like that, Dr. May?
Yeah, that's a very good question. I mean, I think you would need to do a doctor, and a doctor would do some kind of differential diagnosis about what's going on. And sometimes we do have false memories. Doesn't mean that it has dementia. And then I can tell you about things that I swear that happened to me as a child that never happened, and in my memory it did happen. So I think in that case, the doctors could make a differential diagnosis of if this is a neurocognitive disorder, is this just a false memory, or is it something else?
Yeah. Do you have information about how the tool was developed? And then no tool like this. This person took their sister who has Down syndrome to a memory and aging clinic for an assessment, but such a tool is never mentioned. And it seems like a lot of clinicians, and I believe this in the general population, are much more focused on memory than other domains. Can Can you talk about that? And then also, how well known by dementia specialists and PCPs is this tool? And should we all be spreading the word? I'll say yes, but
Yeah.
please.
Yeah, I think this should be used. Ideally, I would love to see this being used as part of just an annual medical checkup with the PCP.
Mhm.
And that's the ideal world, but we don't live in the ideal world. I actually, Lucy Azralu, was part of the committee that developed this screening. And what they did was they used some other dementia screenings that were out there and they modified it to really address people who carry an intellectual disability. And it's unfortunate that more doctors don't use it.
Mhm.
And I have to say, as just someone who works in the field, I use it all the time, and I think it should be part of ideally, I would love to see it part of whether it be a medical checkup or used during the ISP meetings or whenever, you get a
Mhm.
whole team together, because I think it's just an invaluable tool.
Yeah. Yeah, and I think it's important. We do have a lot of information on the NTG website that talks about the tool, et cetera, and even has the guides on how to use the tool, what kinds of questions. But I think it was really helpful to have your discussion on the different points of the tool. So, and I think the more we offer it to healthcare providers, the more it gets out there and the benefit of having it. And I do know that there are a number of Down syndrome clinics, because the Down syndrome medical interest group, which I belong to, a number of them are using the EDSD in terms of that. But it is, I think the more we get information out there, the more it will be used and understood and used, and understand the value of it. So somebody here has a question about, is it better to correct the wrong facts of a memory? Is it better just to go with the memory and let them continue believing, even though if you know it's false?
Yeah, it's something I call therapeutic fibbing. We have, one individual, for example, who every day, he's an older gentleman, in his 70s. His mom, assuming passed a long time ago. But every day it's my mom's coming and we're going to go get ice cream. And we have a script where they would say, "Oh, that's great. Why don't we, do you want to sit down and watch TV until your mom comes?" And he'll sit down and watch TV. I just call it therapeutic fibbing. And it's better just to go in their world than really have an argument. And I know that can be difficult, especially if they're asking about someone who passed and you yourself, are mourning their loss too. I'm thinking about a friend whose grandma has dementia, and the grandma's always asking about a son who passed, and that would have been my friend's uncle. And my friend's mom, always has to fight back tears every time, her mom says, "What time is Bobby coming?"
Mhm. Yeah. Is another question having to do with this person has a question about a family member who's starting taking things, money, pens, toothbrushes, and they had to lock or alarm every door and drawer in their home. Is this common in early stage dementia?
I have noticed that that must be, I know it's very tough, and working with a lot of individuals, I did see that being a problematic thing. I do recommend that maybe you might want to, download the NTG, complete it, and make an appointment with the PCP and see what they think. It could be, other things going on. I don't want to say yes and no, but just in my experience, I have seen it with a few of my individuals, but,
Mhm.
I would
Yeah,
recommend just,
yeah. And there's a question here about the screening, a screening that's used by paraprofessionals, and also the benefit of the EDSD. That's what we're talking about. I've always get mixed up, but EDSD stands for the early detection screening for dementia. That's when we say EDSD, that's what we're saying. And it's the beauty of it there we go, is that
Sorry.
it is filled out by people who know the person the best, which includes family members and, right, includes direct support professionals from all shifts too, if people live in a residential setting, and for people day program and other parts of their lives, right?
Mhm.
So,
Yep.
and that the tool itself, right, and the question about is it better to be used by medical professionals? So it's used, right? The screening is actually is completed by people who know the person best, correct?
Yes,
And then
correct.
it isn't really, because it is a long tool, it is a long thing. So you
Mhm.
don't do it right at the doctor's office, would you, or
Oh,
the
no.
medical professional's office? Great, yeah.
Correct.
And
Yeah, and when I said ideally I would like doctors to have a part of the medical evaluation, I meant before, like, they'll give it out, this,
yeah,
fill this out kind of. And like I said, we use it as part of our when we do our ISP meetings, and because you just have the whole treatment team there, because everyone can give a perspective. And like I said, some the DSP or the person who may work with them at the day program may notice things that the other people don't notice.
Yeah.
yeah.
I'm sorry to interrupt. The questions have been magnificent. Thank you so much,
Thank you.
Kathy and Dr. May, for all that additional information and for answering individuals' questions. And unfortunately, time goes by quickly. It's all the time that we have for this webinar for questions. However, Dr. May is offering to answer additional questions that haven't been answered on the webinar. So please feel free to send them in the Q&A. Or to the family support email address, and we will be happy to forward that information on to Dr. May. And thank you again so much. And thank you so much, Kathy, for sharing those really
Yes,
important
thank you.
questions. I do want to just share with the attendees a couple of resources in addition to what we've shared about NTG. We do offer family resources, and there's a snapshot here with the website address for accessing them. And it's continued as well on a second page. And these are, again, just a snapshot of some of the resources that are available for families and others that are interested in this information. We also do have a monthly virtual family support group that is facilitated by Kathy Service. And I also join in and share my experiences to help other family members as they're going through this very difficult time period. And it is the conclusion of today's webinar. And once again, we're going to thank Dr. May for his time and expertise and knowledge. And just one more friendly reminder before the participants leave, if you would be so kind to complete this very quick, brief, short, it will not take much time on your end, but very valuable information that will be sent to us about your feedback on today's webinar. So that's on the screen now, and I will be displaying it again in just another moment. We are having a third webinar in this series 2 weeks from today on Tuesday, March 26th, once again at 1 p.m. Eastern Time. And the topic will be life planning for different phases of the life journey. And please feel free to email us if you have any questions. And again, additional information is on our website. And as mentioned before, I'm going to go back to the survey link and QR code. And again, if you could take a moment to complete that. And for all our panelists and hosts, thank you again so much. And when the webinar ends, we'll be logging into another Zoom for a quick debriefing. And thank you so much, everybody. It was magnificent. And thank you for giving up your time.
Thank you. Thank you.
And thank you, everybody.
Down there, Kathy Service.
I'm gonna stop the recording.